Right, so today I'll be talking about socket shields, why we do this treatment, essentially, and also we'll look at an example of how it is done. So let's go into the next slide. So the outline of today's talk really is to talk about initially the socket changes that happen after an extraction. So the collapse of the socket that usually would take place after a tooth is removed. And then understanding how socket shield helps to prevent this from happening. We'll be talking about the socket shield treatment and how it can be done predictably. And I'll be very briefly touching on the histology and some of the more common complications and how to deal with them. So firstly, why are we doing this treatment? What is the point? Why is everyone talking about socket shield in recent years? Now, the first thing to know is the socket does resolve or does undergo some changes after a tooth is removed. And with this systematic review, we can see that those changes vary in height between 0.4 and 3.9 millimeters. And also in the width, there's a range between 2.6 and 4.5 millimeters. This is how much the socket is resorbing. We know that the thicker the bone that you have to start with, the less likely it is for the socket to resorb. So if you start with a very thin phenotype, very thin buccal bone, you'll have more resorption. And unfortunately, in the areas where it matters most, you could say in the aesthetic zone, in the anterior maxilla, this is where we have very, very thin bone, which means we're going to have more resorption. 90% of our cases are having less than 1 millimeter of buccal bone thickness, and in half of our cases, it's less than half a millimeter. So let's just put that in visual terms. So on the top of the screen, the top row there, we can see a case that has a thin phenotype, so very thin buccal bone. The tooth is removed. After 8 weeks, we can see a new CT scan, and the image on the top right shows the superimposition of those scans and the difference. And essentially, the red area showing that there is significant difference in terms of resorption of that socket. However, in the lower row, where we start with thicker bone, there isn't much loss of that. Okay, the tooth is removed after 8 weeks. We're pretty much still same kind of volume as what we had before. So why is that happening? So the thin phenotype is essentially bundle bone. I mean, both cases have bundle bone, of course. The bundle bone is the bone that's right up against the socket, right up against the tooth where the periodontal ligament fibers attach. But where we purely have bundle bone, then all of that will resorb. Where we have bundle bone and alveolar bone, the bundle bone obviously resorbs, but the alveolar bone maintains the structure of the socket. So in a case like this, where we've got loads of bone, but just where it matters on the buccal aspect, it's really thin, it's bundle bone. That tooth, if it's removed, then we lose that bone. We then end up with recession and loss of the soft tissue as well. So you can see from this nicely presented diagram, we've got the socket shield. Okay, so this is essentially where a small part of that tooth is maintained. Okay, 90% of the tooth is removed to allow space for our implant to go in, but the outer aspect of that tooth is maintained. The dentine is maintained. The periodontal ligament fibers are therefore maintained on top, which attach to that bundle bone, which keep the bundle bone in place. And then the overlying soft tissue is then held in place. Now, there's been a number of studies on this, obviously, over the years. The very first one in 2010, just to prove that this is a thing. There was a human histological paper showing what happens on histological level in humans, obviously many others for animals. For me, this was quite significant because my MSc thesis was on this topic in 2018, and this is when this one came out. And this was the first sort of decent-sized cohort of patients. And we had 128 patients. We could start to see some more useful data, not just there's a few patients here, it all works, start to see the complications and then also how to deal with them. And then more recently in 2021, we see systematic reviews showing actually, there's no real difference in failure rates between doing a socket shield treatment or just an immediate implant treatment. Failures happen, of course, but they're pretty comparable. But the advantage of the socket shield cases were better marginal bone stability and better aesthetics, improved pink aesthetic scores. Again, in 2023, another systematic review pretty much showed the same thing. So less bone resorption, better aesthetics. So this is the kind of reason as to why we are undertaking such a treatment. So let's have a look at how. How is it done? So firstly, if a case has mobility, if a tooth has mobility, periodontal involvement, then this is not suitable. Okay, the shield needs to be stable, immobile, and usually cases of caries or failed post crowns would be what we'd be looking at. So the majority of the tooth has to be removed. The apex must be removed. The pulp contents must be removed, be that gutta perca or pulp tissue. That all must be removed. Okay. The different ways to do this, and I'll come on to that with the case. We're then left with the shield. The shield needs to be of a significant length and thickness, that it's not mobile. It can't be too long because you may leave the apex. It can't be too thick because we won't have enough space for our implant and our graft. So the thickness is, 1.5 to 2 millimeters is what we'd aim for. The length, a minimum of 6 millimeters. Now, on the coronal aspect, you can see that the shield is prepared supracrestally. Traditionally, that was the initial kind of way it was done. But nowadays, we're advocating for preparation of that shield to the bone level, and even creating a small bevel to help with creating more space for our soft tissue and for our restoration. Implant is then placed in the traditional method for immediate implantology, engaging the apex of the implant into the bone, grafting the buccal jump gap, and making a temporary crown or a custom healing bone. Now, when we look at the prosthetic management, again, so beveling of that shield, as I just mentioned, is really, really important because we want to increase the soft tissue thickness. And there's two ways to do that. So beveling that coronal part of the shield, but also having an S-shaped transmucosal abutment, just to really kind of start very, very narrow and then come out. Both of those things create a bit more space for our soft tissue, and this will reduce the complications. One of the complications is exposures, shield exposures, where the shield comes through, and I'll show you that later, what that really means. So this is Ethan. He's a young chap, very high smile line, in his late 20s. Dentition is pretty good, no restorations, no caries. The only thing is he had some trauma when he was much younger. More recently, he complained of this dark tooth, upper right central incisor. And there was also some bleeding when he was brushing his teeth on the palatal aspect. Unfortunately, he has external resorption. And of course, we went through all the protocols and all the treatment options with him in terms of seeing an endodontist and everything else. But he decided actually he wanted an implant. He had very, very high smile line, very thin buccal bone. So this was an ideal case for a socket shield treatment. Now, some of you may have read some of the earlier studies and think, well, actually, hold on a second, this is absorption. This is surely not suitable. Actually, some of the more recent studies do cover resorption as a treatment option. I think some of the earlier studies had it as an exclusion criteria. It was just excluded from their studies rather than it being a contraindication like mobility, for example. And in his particular case, the resorption was on the palatal aspect, not on the buccal. Okay, so we're removing that aspect, removing the pulp tissue, which obviously helps to stop the resorptive process. So I think, with the conditions that we had in the high smile line, very thin bone all the way through, this is him, then it sort of is a no-brainer to try and protect that bundle bone. So what we do is measure the length. Okay, this helps obviously look at the trajectory of the tooth and measure the length, and it helps us with our planning and how to undertake the treatment. We need to have the right equipment. Okay, so obviously we have our normal implant equipment, our motor and our 20-to-1 latch grip handpiece, and that's useful for what we're doing. But we also need a friction grip handpiece, so a speed increasing handpiece with external saline irrigation. And we need the appropriate burrs. And in this particular case, we use the partial extraction therapy kit from Megagen, and we work through the burrs to produce the shield. The first thing was done, the crown was removed. It was decoronated. You can see the palatal resorption. So first set of drills. I don't like using the number 1 drill. I'll be honest, I think it vibrates too much. So I go straight to the number 2, the Lindemann drill, on the speed increasing handpiece. So the tooth was sectioned in a C shape, you'll see on the next slide, and then the round burrs were used to kind of reduce the thickness, reduce the height as much as possible. So the reason we don't go for a straight line across is we want to maintain the shield in the papilla areas. So it's important to do this C shape to maintain that shield in those papilla areas. And then we use the round burrs to thin that down, but also reduce the height coronally. And interestingly, I said we'll keep the shield to the bone level. That's on the buccal aspect. Interproximally, you want to go up that millimetre and a half to maintain the longer papillas. And because of that increased soft tissue, there's less risk of exposures there. And once the tooth is sectioned, and we've sectioned all the way through, luxator is then used to push the palatal part out with the apex, and we can see the apex has been retrieved here. Sometimes it's obliterated. In this particular case, it's come out in a couple of pieces, but we have got the apex, and it's always nice to see that's been removed. Then use the finishing burrs. So once the initial set of burrs is to sort of prepare everything, and then we finish the smoothened with number 4, smoothing the inside of the shield, the number 5 burr, again, just to finalize the height down to the bone level on the buccal aspect, coronal part of the shield, and then the number 6 really is to create that bevel that we spoke about to increase the soft tissue availability. This is what we're left with. Nice thin shield, not too thin, obviously not flexing, but enough space for our implants to go in. Socket was degranulated from all the granulation tissue that may have been there, all the debris, and immediate implant essentially was placed. 15 millimeter length implant, engaging the bone apically. The buccal jump gap was grafted with an allograft, and then a temporary crown was made, and that helps to maintain the soft tissue architecture that we have, holds the graft in place, and then the patient was reviewed after 2 weeks, and we've got nice stable soft tissues. So an allograft material was used, so we waited 3 months for the implant to integrate, for the bone to take, and sorry, this was the radiograph of the placement, and this was the patient after 3 months. Okay. Interestingly, we maintain that contour, the buccal contour. It's a dual zone grafting, so you can see some graft material in the sulcus there, but nice stable result. Impression taken. Okay, I like to use analog. I prefer to use this flowable composite to pick up the soft tissue. I just feel it's more accurate than the scanners that we have available to us. But yeah, so this was done, and a definitive crown was made. Now, an RC base abutment was used here to angle correct that and keep it screw retained, as you can see from the mirror image here. And this was the radiograph at the time of fit. So everything was nice and stable. The patient was very happy. But what is it like long term? Now, I don't really have long-term data, but I did see the patient after 1 year. It does need to improve his oral hygiene a little bit on the lower incisors, but generally speaking, I think that's quite a stable result. After 2 years, again, very stable. Patient's very happy. We can see the radiographs. Bone levels are maintained. No real issues there. He did have an impacted wisdom tooth, which was close to the ID nerve, so we needed to take a CBCT. I took the opportunity to see what was happening with this after 2 years. And not very clear CT, to be fair. I'm not really sure where the probably guess where the shield is and where the bone is, but it's stable. We've got bone essentially on the whole surface of the implant. So what is happening histologically? I'll just show you one slide, which for me this was the wow moment when I saw this. I thought, okay, wow. There are more recent ones. There is a human slide as well. But if you see on the left of the screen where the arrow is, this is showing the bundle bone. This is the top of that buccal bone. The D is the dentine. This is what's left of the tooth. This is a socket shield. At that time was prepared supraprestally, which was the norm. And the implant is actually touching the shield. Now, you can have the implant touching the shield. Ideally, you want a space. Ideally, you want a graft into the space. But even though the fact it was touching, we can see on the zoomed in image on the right of the screen that we still have bone growing onto the implant surface. The implant's osseointegrated. Some of that dentine's been resorbed to allow for that bone to grow. And in no way has it hindered the implant, but it's maintained the bundle bone, which you can see. I mean, that bone that thin, it would have resorbed. So this for me was quite interesting. And as I say, there are many other histological slides and evidence for this procedure as well. So complications, just briefly touch on this. So, obviously, we know from these systematic reviews, we get failures, but they're not more so than immediate. So let's just park that to one side because failures happen with everything. But specific to socket shield, the most common, and nowadays it's less common, the most common complications are these exposures. The internal exposure, we come to remove the temporary, and we see a little bit of that shield on the inside. Now, the reason it's less common now is now we're advocating preparation of the shield to the bone level rather than supra-osseous, and then the bevel as well. So if we do get a situation like this, essentially a little bit of local anaesthetic, and the shield is then prepared down to bone, sorry, prepared subgingivally, allow for the soft tissue to grow over. On the right of the screen, the external exposure, essentially the same thing. These are less common, but the same thing can happen. The shield exposing itself externally, and maybe a small connective tissue graft in those cases helps, as well as that subgingival preparation. So in conclusion, this sort of treatment helps to prevent that post-extraction socket collapse. We end up with better aesthetics, better pink aesthetic scores. And we know that histologically that bone is growing onto the implant, is growing onto the root. Okay, failure rates we know are comparable to immediate implants as well. Okay, but also, you know, obviously it's technique sensitive. It's not just about leaving and forgetting a bit of root in there. It's about preparing it in a specific way, following the protocols, and hopefully being able to achieve those better pink aesthetic scores. Normally talk about, you know, more evidence is needed. More evidence is obviously always needed with anything, but nowadays I think with the amount of evidence we have, I think it's safe to say that more evidence is now available for this particular treatment to make it a kind of routine treatment. Thank you very much.